So within any further delay, I think we should see whether Stockholm is ready to present the first case. Can we go to Stockholm? I see Navsat and Andreas. Good to see you.
Yeah. Good morning. My name is Navsat Saleh, and welcome to Karolinska University Hospital to show you the first case here. In difference, we had both I and Andreas good sleep and no cocktail, so we try to do the case here. And with me today, my team, Andreas Ryck as the second operator, Ulrika Nilsson, and we have Katarina and Sumi and Synja. And from the anesthesiologists, we have Karin and Lynn. And we have Andrea from Boston Scientific and our recording team. It's a pleasure for us to show you the first case, which is more topic about the small annulus with the accurate NEO2. I let my colleague Andreas to present the first case.
Okay, very good morning to all of you. I hope you had a reasonably good sleep. I think we had, as we said. I'll have a short case presentation about the patient-specific details. So the operators are going to be Navsat and me. Next slide. Conflicts of interest. Next slide. So the patient is a rather healthy 76-year-old lady. She even works part-time in the family business, said as an accountant still. She is rather normal size. She has hypertension. She had a minor stroke last year. There was an investigation about the cause. Nothing was really found. The CT was even normal, and there was no atrial fibrillation on long-term ECG monitoring. The creatinine is normal. The NT-proBNP, as you see, even that is normal. If we calculate the risk scores, the Euro score is only 1%. She is slightly symptomatic with some shortness of breath. So this is from a clinical standpoint, a low-risk patient, but elderly. So according to the guidelines, age over 75, a TAVI should be considered. Next slide, please. ECG obtained yesterday shows also a quite normal pattern with a PQ rather short, only 125 milliseconds, and a normal width of the QRS. So nothing specific there. Next, please. On echo, also quite unremarkable, except the aortic stenosis. We re-measured the gradients again today, and it's exactly the same. It's 4.4 meters per second. It's a mean gradient slightly over 40. The aortic valve area is heavily relying on which number you put in on the LVOT, but it's for sure less than 1 square centimeter. There's no other valve problem. The EF is normal, and the PA pressure is also normal. Next slide, please. Looking at the angiogram, we did a CT angiogram. There is nothing specific there. Some small dots with calcium, but no stenosis. Next, please. Then looking at the CT, this is maybe the most important slide. The annulus is quite small. I think I was even a bit generous when I measured and traced the annulus on the left image, where we obtained a diameter of 18.7 millimeters by perimeter. The largest diameter being 20.7 and the smallest 16.8. And on the video on the right-hand side, you see the calcium distribution, which seems to be quite even on the 3 leaflets, and the calculated aortic valve calcification score is slightly above 1,300, and there is no relevant annular calcification. It's only leaflet calcium. So this is a quite small anatomy considering the more normal body size of the patient. Next slide, please. Looking down at the coronary takeoffs, these are quite normal with a height of 13 for left and 17 for right. Sinotubular junction height is 18, so maybe rather short then. And the diameter of sinotubular junction also smallish at 22 millimeters. The LVOT diameter also on the small side, around 18. Sinus diameters are also on the small side, of course, and around 23 to 25 millimeters. Next, please. So we are going to use commercial alignment as we do routine in all our cases with the accurate here, and also what we call patient-specific commercial alignment. And on the right image, which was turning, I'm just demonstrating an implantation with a so-called virtual valve in the software, and there you can see the three-cusp view, and the goal is then in the three-cusp view to have all the three commissures at equal distance. And then if we go to the cusp overlap view, and then we should have two of the stent posts of the prosthesis overlapping then on the left-hand side of the image, as you see when the image is turning. We calculated the appropriate angles for these two views, and the three-cusp view is at LAO 18 cranial 7, and the cusp overlap view is at REO 17 caudal 18. Perfectly normal numbers, I would say. In the left-hand image, I'm trying to illustrate with the top view how the corner is marked in red and green are situated with reference to the commissures, and this is three-cusp or tricuspid valve, I mean, and it seems like the placement of the corners is perfectly normal. So we place one stent post right at the same distance from the right corner and left corner, and that's the same as putting them with commissure alignment, and coronary alignment will be exactly the same in this patient. Next slide, please. Just talking about the valve, I think this has been mentioned in the meeting before, but we will use a small valve. That's a 23 millimeter valve of the Accurate Neo 2. Maybe we should mention that the target implantation of this system is not 1, 2, or 3 millimeters like it is in some other systems with self-expanding, but we actually target the implantation depths of 5 to 7 millimeters. It has been shown that there is no advantage of getting even lower numbers of pacemakers or better gradients if you place this valve higher than 5 millimeters. So we place it at 7 or maybe 5, and that gives us then a height up to the upper crown, which you see here about halfway up. Of then 19 minus 7 means the upper crown will be at approximately 12 millimeters above the annulus, so well below the sinotubular junction in this patient then. Next slide, please. So access is also quite unremarkable, a little bit on the small side, but we don't see any calcium, and when using the 14 French expandable sheath that is standard with the Accurate, that should be no problem of going in and doing nothing specific more than that, even though these numbers are actually a little bit smaller than what's mentioned in the IFU as a requirement. Okay, thank you.
Okay, Andreas, and that was certainly an interesting case with a lot of discussion points. So I think we'll take the discussion here for 20 minutes, and maybe you can start to prepare the case, and we'll come back to you a little bit. Darren, case with a small aortic anomaly. What to offer these patients? Surgery, transcatheter heart valve replacement, and if you want to go for TAVI, what should you look up for? What platform is going to optimize the outcome?
Well, I think the first thing we have to discuss is whether this patient should have a TAVI or should have surgery up front. 76 years of age, in our guidelines suggest that this patient is suitable for TAVI, and in our institution, anybody above the age of 75 really goes towards a transcatheter procedure. And then I think on top of that then is the issue in terms of small anatomy. We know that if the mean diameter is 19 or 21, our surgeons are going to put in a 19 or 21 valve, and we know that is not going to give us hemodynamics that are similar to a transcatheter prosthesis. So trying to avoid patient prosthesis mismatches is important. We know that the risk of that is much higher with surgical prostheses compared to transcatheter heart valves, particularly in small anatomy. So I think there are multiple reasons why this patient should have a TAVI. And then in terms of the prosthesis type, of course, supraannular valves with supraannular leaflets we know give us better hemodynamics, not just in the cath lab after the procedure, but also on follow-up echocardiography, and that should reduce the risk of patient prosthesis mismatch, should reduce the risk of valve deterioration or leaflet deterioration, structural valve failure in due course. So I think a supraannular prosthesis in this patient is absolutely appropriate. But I'm interested to go to our on-site audience and maybe have some discussions with them as to whether or not this patient would get a TAVI in their institution. 76-year-old, low risk in your institution. Is this a TAVI, or is this would you have a really good discussion with your surgeons?
So I think we'd have a really good discussion with the surgeons is the honest answer. The reason I say that is that in the UK, you may be aware that really there's two sets of guidelines that we practice by, including the NICE guidelines, which came out in 2021 as well. That type of guideline is very much still favouring surgical, but purely from an economic standpoint. Now, we're very lucky that our heart team is a contemporary one, and so we have essentially default back towards the ESC. I think we would have an open discussion about this patient, and of course the patient is at the centre of this. And for the exact reasons that you state, I think we would come to the same conclusion, which is that transcatheter with a supraannular prosthesis is probably in the patient's best interest.
I'm wondering, do we have any surgeons in the audience?
Yeah, I have one surgeon. Yeah.
Being a surgeon, thank you for pointing that out. Being a transcatheter surgeon, there's only one choice for that particular patient, and TAVI is the right option. I fully agree and endorse last year's guidelines. And 76, low risk, but the life expectancy is of nearly 8-10 years. That's what the valve is durable for. And having the patient discharged home on the second day, that's more beneficial than any surgery that you can imagine. So for me, for the surgeon, TAVI is the option one. What I don't agree is the sentence that you mentioned that the surgeons would put 19 or 21. There are ways to enlarge the aortic annulus, and we rarely implant 19 millimeter valves. So surgical option is okay. There are still ways to perform good surgery, good quality surgery, minimally invasive, sternum sparing techniques with the larger prostheses that will allow for future interventions. But for this particular patient who is 76, had a stroke in the past, she's still active, she wants to go back, she doesn't want to have or require a long period of absence and work absence, TAVI is a straightforward option, good option.
Can I just set you one provocative question here? Let's say the patient had been 68 years of age and she was going for surgery. What would be the chance that she would actually have root enlargement?
Yeah.
Little chance, depending on the center to center. These numbers varies. If the large volume centers have more chance of performing root enlargement surgery because it's just more challenging, more risky. But the small volumes, they have little experience and they would just go for regular AVRs. You know, the question should be whether for the 65, 60-year-old patient, should we consider mechanical valve as an option? We still tend to forget that that option is still there. But answering your question directly, little chance.
Yeah. And so, Michael,
unfortunately,
that's certainly the issue in my center, that of course when we come to conferences we discuss root enlargement and how this can allow us to match the type of hemodynamics that we see with supraannular prosthesis, but in reality, certainly in my center, this doesn't happen. What's also interesting is that I think in the past we wouldn't have known that this patient was at significant risk of patient prosthesis mismatch until she gets to the OR and she's already had a sternotomy. And so we've started to do CT scans on all of our patients who are undergoing any form of aortic procedure, be it TAVI, be it surgery, so that we can identify those patients up front and try and steer them in the right direction. Sometimes we do see 65-year-olds, 70-year-olds, and we send them towards a transcatheter procedure so that they don't end up with patient prosthesis mismatch with the surgery, because again, while we talk about root enlargement, it still accounts for less than 1% of surgical practice. In larger centers, as you suggest, with greater experience, I think it's more freely available, but in smaller centers, perhaps not. The other issue that we saw here was that this patient has prior stroke. Interesting to consider whether you would use embolic protection in this patient. Anyone want to make a comment on that, or where do you use embolic protection in your patients? Yeah?
We see this scenario, though, in our region in a smaller and younger patient. Like I used to practice in North America and compare the sizes in our populations. Definitely, we are seeing small annuli. The difficulty I'm facing right now is the definition of small annuli. Can it be, for example, have you seen literature in definition of small annuli based on the patient body surface area and the expected EAO? Because we still use small valve in certain population and still end up with a good effective orifice area. As far as the sentinel device for patient with previous stroke, we definitely, especially patient below the age of 70, we have been using this as a criteria for our use. In addition to a bicuspid valve, and for valve and valve, we have been using it as a standard in some cases. Thank you.
Perfect. So we do the same. We tend to use embolic protection in patients who have had prior stroke, such as this patient, bicuspid aortic valve, valve and valve, or we look at the arch as well on the CT, and if there's a lot of calcium in the arch, that's a patient we would consider using embolic protection. In terms of what defines a small annulus, well, of course, it depends on the body surface area of the patient and then the actual size of the annulus. And we have really great surgical charts that you can predict the predicted effective orifice area in that patient-specific size according to the valve that you put in. So in those smaller patients that we identify with small anatomy, we would take those surgical charts, we would see what an onyx valve looks like, we would see what a perimount looks like and so forth, and then get the predicted EOA from that. But none of them will match. Once you go down towards 20-21 millimeter annuli, none of the surgical valves are going to match a supraannular device, a supraannular TAVI device.
Yeah. So maybe we can also just discuss, let's say that, maybe I can go back to our surgeon here in the room. Let's say the patient would go for surgery. Let's say the patient was significantly younger. Would you take into consideration what kind of surgical valve you'll put into the patient?
What kind of
Let's say you were not going for a mechanical valve, but you're going for a biprosthetic aortic valve.
The choice of prosthesis would depend on patient preferences, an open discussion with the patient, whether she wants the mechanical valve or does she want the tissue valve. And the second choice would be the centers options. Some centers have only a limited number or limited variety of prostheses. Others have multiple. But I think, and what is important to note is that there are new bioprosthetic valves that will enable future interventions for TAVI in failed bioprosthetic valves. And these bioprosthetic valves have the option of being expanded by the ballooning. So these options are available. And I think in majority of centers where you work, you should push surgeons to insert these types of valves in patients that undergo surgical aortic valve replacement.
Yeah, because I think there's two parts to this discussion about durability. One thing is, of course, to give the patient a valve with good hemodynamics and also good durability, but you also have to think about what's coming next. Because the valve is eventually going to fail if the patient have a longer life expectancy. So how to be able to actually to revalve the patient later on.
Exactly. This is something that we have to have in mind. This is the topic that we should discuss with the patient and with the surgical and cardiology team, how to manage the life of that particular patient. What choice should we make now to facilitate the future intervention? That is most important now.
And among your surgical community, your colleagues, is there sufficient awareness about this lifetime management of the patients?
I don't think it is. So we should be talking about it. We should be talking, explaining to the patients. The patients will then put the pressure on the team to have that discussion. You know, I'm like 70. We had that situation 2 weeks ago. The patient was 70, and we've discussed it with the patient. You know, we have to have options for future interventions. What you would like to have now, whether you would go for regular AVR and, you know, have a risk of 2% with the surgery, but prolonged recovery, but that will give you an option 7 years from now, 8 years from now for transcatheter approach, or would you like to have TAVI now, you know, faster intervention and like second day discharge, but we don't actually know what is going to happen within 7, 8 years, whether that intervention, future intervention will be easy, difficult, challenging. So there's lots of questions.
Yeah. So Michael, that's a really great segue, I think, into the discussion around what valve we should choose for this patient. Okay, this is a Boston Scientific sponsored seminar, but let's talk about what this patient could have, right? This patient really is a good candidate for most valves. We could get most valves in and out of this patient safely, but we've taken our focus a little bit away from the procedural outcome, which has become standardized, predictable, reproducible. And of course, we're looking a little bit further down the track now, as Michael, our surgeon, has said, in terms of, well, what about coronary access? What about revalving? What are the options for this patient with different prostheses? As well as a patient, of course, who has a very small anatomy. So I think most of us here would suggest that a supraannular valve is the right choice for this patient, whereby you have a very small anatomy, so we get better hemodynamics, we get better gradients, and most likely we get better durability of the valve. But what about coronary access, and what about revalving? These are two, I think, very important questions that we need to consider in a patient like this. Can I ask a member of the audience, in terms of reaccess, what's the right valve choice for this patient?
To the coronaries.
Reaccess to the coronaries. So this patient develops STEMI in 6 years' time, or develops, for example, calcified coronary artery disease in 12 years' time because she's still alive. She's still an accountant, so she's going to be here. Taxes and death, right? Two things that are sure. Anyone want to make a comment on coronary access and your experience with coronary access after an upfront TAVI? Yeah.
The SAPIEN are accurate. We discussed this yesterday. Okay. Between 90% versus, I think the data versus 100% for, or 90 and 99% versus the tall self-expanding valve. I'm not sure about the Abbott valve, what is the data about that, but clearly SAPIEN and the Accurate has been shown to have the easiest access. Okay, so SAPIEN has great access, absolutely. If you can keep it below the level of the coronaries, in this patient that should be okay. But the gradient might be an issue. So good access, gradient may be an issue in the longer term. Let's think about, for example, some of the other self-expanding valves. Gradients might be good, but access then might be an issue. And in terms of commissural alignment, you can't commissurally align a SAPIEN. Others you can, 75% of the time. But is it okay to have access to the coronaries 75% of the time? It's probably not in the longer term, right? We need 100% coronary access. It's not okay that one patient turns up and we can't access their coronary arteries. You had a comment.
So looking at this specific case, probably just because of the annulus dimension, I would prefer a supraannular valve. I think Accurate should provide some advantages as compared to other supraannular valves just because of the low profile of the valve. So if you optimize the implantation with the good alignment, you can use the low profile valve to guarantee. And this is a very forgiving anatomy in terms of reaccess because the coronary height is not a problem, but looking at the future probably as a second hope. So first platform Accurate, prefer to other supraannular valves just because of the low profile and supraannularity, and then second platform a balloon expandable just to avoid self-expandable in self-expandable that we know is not a good option.
Thanks, Francesco. And I'm going to take that point on because you mentioned the option of revalving and Accurate, right? And I think those of us who are involved in the space think that this might be a good option. But I see Chris Frawley is over in the front here. Chris is the lead engineer with Boston Scientific, leading up the possibility of putting a sapien valve inside an accurate. Chris, is it possible to put a sapien inside an accurate? Can you tell us what work you're doing in this respect?
Yeah, we've started a fairly comprehensive series of bench testing. There should be a publication coming through in the next few months from Janar in Canada. He's led a lot of that as an independent investigator. The bench data is very promising. It looks like they're quite complementary. We focused on, if accurate fails, what's the best solution? And what we recommend is not another accurate, because then you do pin out the leaflets more and it's going to be harder for coronary access. So as a company, we actually recommend a competitor's valve for the best solution as a second valve. And I think Medtronic do the same. It seems reasonable that when supraannular valves fail, an intraannular valve is a good option. And maybe the opposite will also be true. When intraannular valves fail, maybe supraannular would be a good option. In case experience, it's limited, but I know of at least 10 cases where it's been done now across Europe. Obviously, valves don't fail that early, so accurate's still a relatively young valve. It's only 8 years since CE mark. But of those cases, they've all gone very well. And in fact, Professor Grieger has done one of those cases and had a good experience.
And so Marek, let me just ask you one question, Lars, and I'll come back to you. So we've all limited experience of this, but what is the advantage of having an accurate in first and then putting in a balloon expandable valve after? Why would we do that? What is the benefit to the patient in terms of that lifetime journey?
Yeah. In fact, we tried with the self-expanding valve, so the accurate, and that accurate, which in the procedure which I had done in my center, the valve degenerated because of endocarditis. So it was an early degeneration, and of course, as Chris mentioned, we started to think, what are we able to do? At the beginning, the first thought was to put the second accurate, but Chris showed us the animation and data from the lab that it's a bad choice. And with the putting a sapien there, it was an excellent view and with extremely easy access to the coronary arteries. Yeah. So it was perfect, and we showed it before. Just before implantation of the second valve and immediately after. And it was as easy after as it was before. Okay. So it's definitely a good choice. And moreover, that valve was implanted, as I mentioned, 3 years ago, I believe. So no one was talking about the commissural alignment at that time. But anyway, we were fortunate because more or less that valve was properly aligned. So that's why it was easy, and nothing has changed after sapien implantation as a valve-in-valve.
So in terms of the advantages of that strategy, not only do you maintain coronary perfusion after the second valve is implanted, but you maintain coronary access. And that might be a unique situation when you have an accurate as your index valve. Chris.
Thanks very much. Just to add to the lively discussion as well, perhaps also just thinking about the STJ, which sometimes, is perhaps something that we don't pay sufficient attention to. So with this sort of small anatomy, this tubular anatomy, I think there's 2 points to raise potentially about the STJ. If you are putting in an evolute as the first valve, then when thinking about the coronary procedure that may come later down the line, you've actually created quite a narrow working space with regards to the intubation of the guiding catheters for your PCI procedure. And the second aspect is also then when we're thinking about revalving, is the concern about essentially sinus sequestration as well. So I think those are 2 important things that certainly for me, the STJ anatomy is also equally as important.
Yeah, that's a great point. Thank you. Lars.
Now, just a final comment before we go to Stockholm. I mean, for people who haven't seen that, if you have a supine leaflet position in your valve, and you're going to put a high stent frame in for the second valve, you're going to push those leaflets aside, and you're going to have a very tall, a very high, what we call a neoskirt, which is going to make it very difficult or even impossible to access the coronary arteries. So the trick is that for the revalving, the next valve, you put a balloon expandable valve in with a shorter stent frame, and your neoskirt is actually not going to be higher than if you're doing a sapien in a sapien valve. So you will have better access to the coronary arteries. On the other hand, part of the leaflet from the first valve is going to have what we call leaflet overhang. It will hang over the second valve. But at least on the bench testing, it's been shown that it doesn't impact the hemodynamic of these valves. So that's certainly a way to go forward when you start to think about lifetime management of these patients. But then I think we should go back to Stockholm to Navsat and Andreas. Yes, we see you.
Yes.
Okay.
Welcome
Thank you very
back
much.
to
Thank
Stockholm.
you for that discussion. We have discussed along the same lines with the patient selection, with the small anatomy. Also here, we pride ourselves of being the biggest surgical institution in the country, and I must say the number of root enlargement at Karolinska for aortic valve replacement is low. So I'm not really sure she would have received a root enlargement if she would have been 10 years younger and gone for surgery. We have moved forward a little bit. We have put in the radial sheath and a small pigtail, 5 French up to the aortic root. So I just wanted to mention, put up a few slides on commissural alignment. So we can go to next slide, please. Just to explain, maybe you went over this yesterday in the meeting, but I just thought we might explain it since we will use it here. So this valve is unique in one way that it has lots of markers which you can see for patient-specific commissural alignment. On the left-hand side, I pointed out in right the stent posts, and they are clearly visible, and there are 3 of them, which makes it easy to see the rotation you have on your catheter in the patient. Just under each post there are 3 so-called free cells or wings. These are small parts by the upper crown which stick out a little bit when the valve is not deployed when you come up to the aorta. And the aim is of course then to have 1 post and 1 free cell exactly in the middle between the right and the left coronary artery, and by this way you have the maximum clearance from the coronary arteries. Next slide, please. So the technique has been developed here and at some other centers, and what's important to understand is that you need to work out the patient-specific angulations you need to have for the implantation, and these are the classic 3-cusp view, but you also need to use the right-left cusp overlap view, and the reason for that is that the perfect alignment and the perfect misalignment will on the 3-cusp view look the same, but you can distinguish them by checking in the right-left cusp overlap view, which in this image I think is the left one, and there if you see 1 free cell sticking out on the right side of the image, the so-called inner curve, then you know that you have the right orientation more or less of the valve. Then you go to the 3-cusp view, and there you can really perfect your rotation of the device by turning clockwise or anti-clockwise. So my rule of thumb, which I try to remember, is 2 outer rotate clockwise, T-O-R-C, torque. So if you have 2 outer, which means then you have a little bit of a free cell sticking out on the inner side, then you rotate clockwise. If it's vice versa, you rotate counterclockwise. You could rotate either direction, but this is the shortest way and the least amount of rotation needed to come to the perfect rotation of the valve. And from this point on, then you go down the last 5-10 millimeters to the position of the valve and position the dot at the annulus, and then the rest of the implantation continues just as normal. Next slide, please. We showed some data here on 170 consecutive patients when we started this process now over a year ago. In the beginning there was a lot of discussion if this technique was applicable to all patients or just patients had really straight arteries, no tortuosity, good iliacs, etc. But we from the beginning tried to do this in all patients. And we had a few patients where we couldn't analyze the images because the post-implant fluoroscopies were not good enough, but otherwise when looking at 167 of these patients where we had tried alignment, 97% of them actually had no significant misalignment with none or mild misalignment, and only very few of them had moderate or severe misalignment. So it seems this is achievable in almost all patients. You can do it also in tortuous anatomy. It might take a little longer for the rotation at the handle to track up to the aortic position. We checked the time it takes by looking at the time stamps on the fluoroscopies, and in this series it's an average of 92 seconds to achieve the alignment. So it seems not to add much time to the procedure. Next slide. So our plan, as we said already, awake patient, have the main access, and so that's the next thing coming up here is the main access, right femoral. We have something that is a little bit new to us. I don't know if anybody else is using it. We have this long stick. This is a 30 centimeter version of the micro access kit. So with this one, you actually come up directly from the micropuncture with your small wire and the 4 French catheter all the way up to the aorta. So by this, you can actually go directly from micropuncture to stiff wire and then go to your big sheath that you need for the procedure. Then the rest of the plan is then the valve crossing. For this, maybe some others use it as well. We tend to use the EMAC catheter because we think it's safer when you have the catheter in the ventricle. When you go out with the wire, less chance of hitting the ventricular wall, especially maybe in small anatomy. So less risk of injury to the left ventricle by the wire. Then pre-dilatation, 80 millimeters balloon. Since you saw that the ECG is normal, we'll not put in a temporary backups pacing system, so we'll just use the wire pacing. See that later maybe.
Yeah, just show us.
So these are the 2 connectors. I think lots of people are using these nowadays. Red and black connector, and you connect the red to something that's connected to the patient. We usually put a small wire in the skin in the contralateral groin, and then the black one, you will see it later, will be connected to the wire that goes into the ventricle. We will put in a small valve, as said. We will use commercial alignment, as said. Target implant depth is, as usual, 5 to 7 millimeters. And in the end, we'll close with the MANTA closure device, which you will see also. So I think next step is for...
Yes, just one comment about the Sentinel. I think because in this case
yes.
it was it's very bovine. That's why we escaped to put in Sentinel. I hear the comments. It's a good comment.
Exactly. So the anatomy was actually unsuitable. It was screened for on the CT for Sentinel, but unsuitable anatomy in this case.
Okay, as Andreas mentioned, we already put in A-line and the radial sheath and pigtail catheter, and just
I'll put the ultrasound on the big screen so it's more easy to see.
Karin, kan du trycka på frysknappen, tack? Okay, frysknappen.
Bra.
Yeah, thank you.
So we just heard a ACT of 280, so now we're going to puncture the common femoral artery under ultrasound. See, it looks a bit smallish here also. A little bit of calcium on the vessel, but not much. Nafzad is having local anesthesia in a syringe for the puncture needle. And the advantage of that is, one, you can put some local anesthesia on the front wall of the artery, which makes it even less painful for the patient. And the second one, when you push in the local anesthesia through the needle before you reach the artery, you will actually have an indication more clearly where your needle tip is if it's difficult to visualize. Now we're going in with the micro wire. In this case, with this long microcatheter, you get 80 centimeters of micro wire, so that's a lot. So you see it goes up directly to the aorta, and then we come in with this very long 4 French sheath that you get with the micro access kit. So this is maybe not very important for the outcome of the procedure, but simplifies things a little bit and makes it more streamlined and saves some time. I see the 4 French sheath is up to the aorta. Go directly to stiff wire from here.
Andreas, I noticed that you're planning to use the MANTA device to close.
Yes.
Do you do that in all cases in Karolinska?
We actually do it in all cases. We haven't found scientifically any reason to not use it in some patients. We looked at it quite thoroughly. We published a cohort of 1,000 patients recently looking at different risk factors for failure. So it's I think it's something you could use even in small anatomy, small arteries. The unique thing with the MANTA, we can mention it in the end, is that you have a small risk of occluding the artery mechanically with the anchor. So you should always check for flow, but that can be corrected with a balloon if that happens. You should always check for flow with your ultrasound. So we keep the ultrasound probe on the table until the end of the procedure. Next step now is to measure the depth to the artery with the MANTA.
Any comparison between those two devices the suture-based and the plug-based?
Yeah, so we've seen some data published recently, presented at TCT by Mohammed Abdel Wahab from Leipzig. So they did a 3-center randomized trial comparing 2 per closes to the Manta device, and found a higher rate of vascular complications and bleeding with the plug-based device compared to the more traditional suture-based therapies. Certainly in their experience, and it's a single study, suggesting that the more traditional suture-based device carries still some advantages over a plug-based device, but again, it's a single study. But certainly has given us food for thought in terms of moving exclusively towards Manta.
Mm-hmm. Yes, we've seen that.
There's also quite a few sites who make a combination of suture and plug-based. So you have like a ProGlide or ProStyle, as it's called now, and top it up with a small plug-based device as the AngioSeal.
Yeah, we're still a little schizophrenic in our approach. Actually, we still haven't decided what the right combination is. I think when we go towards larger sheets, 18 French, we tend to use 2 per close and then add an AngioSeal on top. On the other hand, sometimes when we're 14 French, then we tend to put in a single per close and an AngioSeal. So I think all of these are good combinations. I think it's good to have 2 or 3 techniques that you can use and adjust that according to the specific patient that you have on the table.
And also I think there's this sport now about how low can you go, how less one ProStyle and but I think if you want to have your patient home the next day, I mean, you really need to make sure that you have a good closure of the vessel. Otherwise, the patient is going to stay in hospital. Yeah. So we are also very liberal to add AngioSeal in the cath lab in order to have a good, safe closure.
Yeah. We tend to do that because the nurses in the coronary care unit really get quite upset if the patient has any oozing at all. So we make sure that the leg is dry before the patient leaves, or else halfway through the next procedure, we have to go to the coronary care unit, check the patient, and come all the way back. So we do it not for the patient, but for the physician.
Okay, Andreas and Navsat. So you put the eye sleeve in, I see.
14 French eye sleeve is up.
Yes, and we now we go with the IM catheter.
Next step is valve crossing.
Could we see the fluoro on the screen? It would be great, please. We see very nicely your hands.
That was intended, yeah. So we'll go to for this, you can probably do the crossing in any angle, but then we go to one of the predicted angles, which is left 15, crane 7.
Andreas, left radial pigtail, is this your standard approach?
Yes. In the beginning we used the right radial sometimes, but you tend not to come to the non-coronary cusp when you go from the right side. So left side is really preferred for that, since then you come automatically in the outer curve of the aorta and to the non-coronary cusp. Maybe we should mention some small tweaks. We use a extra small curve pigtail always because it sits more nicely in the bottom of the cusp. I think a normal pigtail is around 17 millimeter diameter of the pigtail part, of the curved part. This one I think is 13 or something.
Andreas, there's a few questions from the chat. I can maybe ask you why Nasat is crossing the valve. First of all, at what time point are you giving heparin?
At the first puncture.
Full dose of heparin as soon as you have punctured. Yeah. Mm-hmm.
Yeah, and aim at ACT 250. Yeah. I think this patient has achieved ACT of 280 now.
Yeah, and there's a second question. This patient had a stroke last year. Is this a patient you would consider to use cerebral embolic protection device?
Yes, good question. According to our guidelines, we should consider it, and we did, but as said, the anatomy is not suitable because of bovine arch first, and also small diameter of the carotid arteries. So it's actually not within the recommended size range, at least.
The heparin question is an interesting one, Lars, I think. We do exactly the same as the guys in that we use a micropuncture kit. And really that gives you great safety in terms of giving heparin early, in that if you have a puncture that you're not happy with, it's simply a 3 French dilator, so you can take it out and press for 1 minute, irrespective of whether you've given heparin or not. We do the same thing. We get the puncture, we give heparin straight away.
And I'd like also ask a question of the catheter which you use to cross the valve, because Andreas mentioned that they use Lima, and what about you, Darren, Lars? Because we are using, let's say, traditional Amplatz left catheter, and what about you?
We're the same. We're an AL1 for standard cases, and if the anatomy is challenging, horizontal or very large, we would upsize to an AL2. Equally, I don't think it matters hugely, to be honest. I think it's whatever you have available and you're comfortable with in your institution.
And we're also very conservative. We still introduce the stiff wire under a pigtail catheter.
Yeah, we are doing the same.
So
and to cross the valve, the guide wire, hydrophilic or standard one?
I start out with a standard straight wire. I think it's give you a little bit more support, but if it doesn't work, I will go for a hydrophilic wire.
So we are doing
same thing. Guys, in terms of the Safari wire that you've chosen, a small anatomy, would you go for an extra small Safari or a small Safari in this case?
We usually use extra small in all our cases. I think it's much better to use this one to get it in the apex, especially for this valve, as you know.
So then where the wire is in, and just commenting on the wire exchange procedure in the ventricle, I think the advantage of having the EMA is this short tip. So if you go directly for the Safari, as you see in this case, it comes out easily inside the lumen and it's not hitting the wall as much as if you would do the same with the Amplatz left catheter. Small detail, but maybe also important in some cases.
If there are questions or comments from the audience here, you in the room, please just raise your hand and then we can certainly integrate that into the discussion.
The balloon, by the way, is a non-compliant one. It's the true dilatation at 18 millimeters. It's coming up now. And when we have the valve...
And Andreas, how did you decide to use an 18 millimeter balloon? Is any... What was that measurement that this decision made on?
The predicted annulus size, or the average, is 8.5 to 19. So we should use a little bit smaller than that. Our tradition is to use about 1 millimeter less than the perimeter derived diameter. And actually the choice is quite easy in this patient, since there is no smaller balloon for valve predilatation than 18 of most brands. So this is the smallest one, at least from the true brand.
Okay.
So we'll do the pacing with the left ventricular lead rapid pacing. So it's going to be a really brief pacing, and this balloon actually it goes up and down really quickly when you inflate and deflate.
Can I see it? Okay,
thank you. Pace at 182 per minute. Balloon is coming across now.
Pace ready? No, wait. Pace ready and balloon ready?
Just a second. We hook up the black connector here. Red connector is on.
Okay, so
balloon is ready.
Pace on. Balloon up. Balloon down. Pace off.
Pace off. You see, that's really quick. She loses the blood pressure just for a few seconds. Take out the balloon.
Okay, take the valve, please.
And you know that the first step nowadays with the valve is to go in with the flush port, which you see here pointing down towards the table. That's what's called 6 o'clock. Lots of 6 o'clock procedures nowadays. And then we'll introduce the valve into the vasculature, and then when we go up, we will actually do some checks on the rotation of the valve. And for scientific reasons, we'll also actually check in the descending aorta, which we use for some of our studies. I have the wire.
We do pre-dilatation in all your accurate cases. There's a question here from the chat. Pre-dilatation in all accurate cases.
In all evolute cases, you asking? Yeah, okay. In evolute cases, I predilate only when there are accurate or evo. Accurate. In accurate, I predilate in 100% of cases. It's my approach. With the other valves, it depends. With the other valves, cell-expanding valves, I only predilate when there are a huge calcification of bicuspid anatomy. Except maybe also Navitor. In Navitor, I predilate in maybe 80% of the cases.
Darren, there's also a question, does it matter whether you inflate the balloon fast or slow in terms of the risk of aortic regurgitation?
I don't know that it matters, to be honest. I think what's important is that you get a good predilatation. Particularly with the accurate system, we know that this system has good radial force but doesn't have great opening force. That is to say that you need to give it room to expand. And so you could see, although that the predilatation was done quickly here, it was also done very appropriately in that there was no residual waste on the balloon. So take your time, do a good predilatation, and your case will be relatively straightforward.
So Andreas, now you're set for doing your commissural alignment. So just take us through step by step. Where are your C-arm position and what are you looking for?
Exactly. So maybe you don't see the angulations, I think, but we have now selected the cusp overlap view and we save it on our system, so we can go easily back between this view and the 3 cusp view. If you see the hemos, I think you do, then you see that at this point we actually, when we are slightly across the valve, the hemodynamic is excellent. So we can take our time now. And if we look at this image, we see a so-called free cell sticking out towards the right-hand side of the image. If you see that in the REO view, you know that you are already more or less correct. We're not upside down, it's the right direction. We have in this view both coronaries on the right-hand side of the picture, so want one free cell between them. So then we go to the left, to the 3 cusp.
So this was a left-right cusp overlap view, and as you said, in this view, you want to see one of these free cell stent struts pointing to the right of the screen.
Yes.
And now you're changing back to the 3 cusp.
Now we changed the angulation.
View.
This is a traditional view, a coplanar view. And here the ideal view is to see one wing on each side. But as you see here, clearly there's only one wing on the outer curve, that is the left-hand side of the image, and further up on the stent you see 2.
So I'm just pointing here on the screen. So what you're looking at now is the 3 posts here, which should be 1, 1, 1.
Yes.
Yes, and these are actually here 1 to 2. So 2 in the inner curve, 1 in the outer curve. And that's also the reason why you see one wing on the outer curve. There are 2 more wings, but they are not seen since they're not in the outer curvature.
And Andreas, before you do anything, just explain. Now you saw 2 on the inner curve. So what does that tell us? Is it counterclockwise or clockwise rotation?
2 outer is clockwise, 2 inner is counterclock. So this is a counterclockwise.
So he'll be counterclockwise.
Yes. And we expect also to turn you need to turn the handle at least half a rotation before you see any rotation at the aortic level. So you don't expect it to be 1 to 1.
Can we focus on the handle while you're turning?
Yes.
Can we see the handle while you turn and see how you do it?
Yes. I just don't hold the knobs. I think the more safe is to just hold in the catheter.
I see already that this wing on the left-hand side becomes smaller, and you're starting to see a wing coming in the inner curve soon, which is approximately here.
So,
and here you would stop, take an image, there's no rush. You would release the handle to dissipate any tension or torque in it. Confirm again if we want.
So you saw Andreas and Navsat was turning the handle, was at least 180, maybe even 360 degrees. And as soon as you had the position, you just let the torque go, let flip back.
Yes. And in this instance where we already have confirmed from the beginning that we were not upside down, we don't need to go back to the cusp overlap view, otherwise we would do that. So we can stay in this view, which is what most people use for implantation still. There's some discussion in the field if you should move to another view, but we think this traditional coplanar view is probably good, since you see how much, it's easy to see here how much you lean to the outer curve of the aorta. which is the idea with this valve. So we'll just go down and implant
Yeah,
from
so
here
now
on.
we go down and
The dot
Can I
marker,
ask you
as
one
know,
question
it's
before you do that,
approximately
Andreas?
7. Yes.
Okay, you do your talk here with you already crossed the valve. Could you do it with the system just above the aortic valve?
We tried that, but if you are higher, because of the banana shape of the aorta, actually your angulations will be slightly off, so the precision will probably be less. You can do it, but the further away you are from the aortic valve, the less precise your alignment is going to be, and it's going to change then some degrees when you go down the last centimeters. We'll soon see some contrast coming to confirm the position of the pigtail.
contrast.
And just remind us about the landmarks here, Andreas.
Yeah.
Yes, so the dot, which
Is
is
it
actually on the
Right. as well.
the dot sits on the delivery system, so that will not stay in the patient, is at 7 millimeters up. So the idea is to have the middle of the dot is 2 millimeters high at the annular level. So here it means we should go down approximately 2-3 millimeters more. Something like that, I think.
Contrast.
Seems pretty good to me.
Yeah. So
Do you agree?
we try to open the. Oh,
It went down a bit more. But
Can
you
we see the handle? We
counteract
don't
that.
want to see your face, sorry, but we want to see the handle, Andreas.
yeah.
Okay, sure.
Okay, so it's dancing a little bit. So take a little bit contrast. So I think
Okay.
we can open it there.
Some heavy breathing on the patient, so it's moving a little bit. We'll open quite slowly here. And usually when you open like this, then it locks things
Contrast.
in a little bit. And it becomes a bit more stable. So here we're a little bit on the high side, so we push a bit on
So I
it.
try to go down just maybe 1 millimeters.
And with this wedge shape that you have now, then it prevents you from going too deep usually.
Okay.
Contrast?
Contrast. It's okay.
Good position. And we continue to number 1. So this is then the second half of the first step, we could call it. And we'll go on until we have a full opening of the device, which is here. Good.
Contrast.
Confirm. In good position.
Yeah. Okay.
Approximately
So
6 millimeter steps. Then usually we take out the pigtail and deploy the rest.
okay.
Right. Take out this safety pin, and then the number 2 is supposed to be quick. So now, yes. Good.
Okay.
So maybe if you just look
We see the
at
stent holder
yeah,
detached.
the stent holder should deploy
make it
forward, which is that done here. So
sure
then you know you're well deployed. Take back the wire. Will take you more central into the valve. And then from now on, it's the assessment of the result. We can see already that the stent frame looks quite well expanded, considering that the patient only has this 18 millimeters of space here. Of course, if this would be a larger
Andreas,
annulus,
are you
we'd
still in the
expect more.
three-cusp? Are you still in the three-cusp co
Yes.
plan of view?
Yes.
So what do you
what's
think
your
about this
comment on
stent
that?
post here?
Not ideal, I think. So we are approximately 30 degrees off, but to assess it more properly, we would also like to go back to the right-left cusp overlap to see.
So I think what
Actually, in
Lars
some
is
cases
alluding to
looks-
there is that, in this...
Yeah, we don't have the 1-1-1 here. We have a...
The stent post should be equally spaced. We should have one here, one in the middle, and one to the side. And we see that this middle one is over towards the inner curvature of the aorta. That means that we're not perfectly commissurally aligned. But the nice
This
thing
is
about
on the
this
other
system
view.
is that is...
So here it actually looks more... I predicted this also actually from the CT, since if you want to have it perfect in both the left cusp overlap and the coplanar view, then you actually need to have an exact distance in degrees between the two angulations on the CT, and I don't always get that. But it's a fairly good alignment. We have to calculate the numbers, but probably 15 to 30 degrees off, which means mild misalignment, I would say.
Yeah. And I think that's an important comment, Andreas, that if you go through these steps, even if it's not perfect, you never get a case of severe commissural misalignment. You should get at most mild commissural misalignment, which is what you see here. You're probably 10, 15 degrees out at a maximum here.
Yeah.
Also interesting to note that the hemodynamics of the patient never changed. The deployment was just very smooth, very easy for the patient hemodynamically, and your ECG appears to be unchanged as well.
There's a few questions from the chat here, Andreas. One is asking, do you ever use rapid pacing when deploying it?
No.
When deploying this valve, rapid pacing never. Fast pacing we have used in a few instances where you have lots of movement on the valve before you start deployment, some instances like that. Or maybe mixed disease with lots of regurgitation as well as an stenosis. Then that might help, but it's really infrequent, I would say.
And there's a question about did you measure hemodynamics before the valve implantation? Are you going to repeat it afterwards to have some kind of assessment of degree of paravalvular leak?
Actually, we used to do that a lot a couple of years ago, but now I think the problem of the paravalvular leak is much smaller, so I think the leaks we see are not always picked up by measuring the LVEDP, so we don't do that routinely before and after. It can be done in some cases. We haven't measured it obviously before in this case. So I think the most common discussion here is if we see some leak on the ultrasound, is it paravalvular or is it wire leak, since we tend to leave the wire in after deployment here. So we have our colleague Anna Damlin here, who is an echo expert, and she's doing a thorough assessment on the echo. I heard yesterday on the meeting I had discussion, I think from Rotterdam, about the quality of the ultrasound in the cath lab and the next day on the ward. And certainly there can be a difference. So if we are in any doubt that we have a relevant paravalvular leak, we will post-dilate. That's the policy here. We don't want to have any surprises the next day.
You guys see the pictures? Echo.
We see
We're trying really to hunt down some PVL. You see the wire in the ventricle here as well on the ultrasound. Yeah. So far I haven't seen anything relevant, but we have time, so we'll look thoroughly. And our routine is that all patients, except patients with severe renal failure, will also have an aortogram. And we have analyzed these with this system that is called the quantitative aortography as well in some studies, where actually can quantify the degree of leak in % as well. But I think also just the simple eyeballing test with thorough injection of contrast tells you a lot. So what do you say, Anna? Have you seen any leak?
There's a question about the pigtail. Do you ever leave the pigtail during the valve deployment?
In fact, we are almost always removing that because I think that it's easier to remove it before, because when you leave it, there is still, maybe low, but still likelihood that by removing the pigtail after, you can dislodge the valve. And I have seen cases like that, so I try to remember that and remove pigtail before deploying the valve. And I'd like to come back, in fact, to the pacing during deployment, because my strategy is, in majority of the cases, to pace something like 110, 120, because I think with that the valve is more stable during implantation. So with accurate, I prefer to just to pace 110, 120.
Kan jag hämta en pigtail till?
So I'll maybe give a counter view. So we don't pace during accurate deployment unless there's a specific reason to, for example, aortic incompetence. And then in terms of the pigtail, I leave it there. I like to see the final movement of the valve relative to the pigtail to understand whether it's stayed still or whether it's moved. But we're very cautious taking it out. It's an extra step to take it out afterwards. We always take it out with a wire, so we push a J wire out to straighten the pigtail. We've never moved a valve with that strategy, but of course it depends on your local practice. Andreas, we don't see a lot of PVL here.
Leakage on the wire.
No, and we actually the case was also selected to discuss the gradient. So I don't know, Anna, can you put up? I think you measured the mean gradient. Here, this is now without post-dilatation and in a normal sinus rhythm with normal blood pressure. And it seems the gradients are very low. We predicted a mean gradient of 8, so let's see if that's, maybe the measurement here is even lower, but of course there's...
You predicted of 8.
So it's 5 the gradient.
So we measured it 4. I
Okay.
think that's maybe some underestimation here, but still it's clearly less than a standard surgical valve, if we say that. Then maybe we can discuss, some people like to exchange the Safari in this position for a pigtail before taking the aortogram, or even before taking the echo, with the argument that the stiff wire here, the Safari, might provoke some leak within the valve. We're not sure what's the answer to that here, but just since we have lots of time, maybe we measure, we can show you the LVDP on the screen here soon. So we can only have with the standard setup here 1 pressure at a time. So maybe we switch to the left ventricular pigtail and just show you the pressure tracing, and after that I think we should proceed with the aortogram. Some extra beats coming here from maybe from the pigtail itself, so we can
Andreas,
retract it in millimeters.
Could we ask the team in the cath lab, Andreas, to enlarge the hemodynamics? They're somewhat difficult to see.
We did that. Yeah.
Perfect. Thank you.
I think you will see it here. Now we flashed the catheter with saline. We'll wait, and the calculations on this system takes 10 heartbeats to calculate the numbers if we trust the automatic numbers here. So it's a 150 scale, which means that these small dots, the lines, are 25 millimeters apart. So we have LVDP around 10 or something, which seems good to us. So that means we would probably leave the pigtail in the ventricle and just inject contrast into the aorta. And the contrast injection into the aorta should be in a good projection where you don't have overlap with the, especially not with the ascending aorta or any relevant structure. The LV should be projected free from any background. So maybe this REO view is actually quite good in this patient.
Yeah, the video densitometry view tends to be very REO and very caudal.
Sorry. Here you have it on the big screen. And just put this. Vänta, jag ska bara flytta upp eller övervakningen lite upp. So we could maybe even perfect the angulation here, since we have time. We have some overlap with the descending aorta. The contrast will come later there, but still. Yeah. So let's try to find.
Okay.
And also one advantage of working in this REO projection when you do your final injection, okay, now you went back, is that you don't have any overlap.
This is actually LAO.
And the descending aorta.
Ska vi backa den piggen lite där? Just making sure that we don't catch the valve with the pigtail. Look and play back the image. See a tiny puff of contrast going to the left ventricle, but it's really minor, I think.
But I think for me it's very tiny, so I think we can leave it, because the gradient is good.
I think we can also stop the image like here to see the implantation depth. We measured the sinotubular junction height, as you remember, to be 19, the left coronary to be 13. And we know the height of the valve, so even if we don't see the bottom of the cusps here, we see that the upper crown sits at approximately 14 millimeters up. So that means 19 minus 14, we have about 5 millimeters implantation depth, which was, I think, the goal of this.
So Andreas, back to the PVL. I mean, you have done echocardiography, you have done some hemodynamics, and you've done an aortic root injection. Try to summarize what your consideration of PVL is in this specific case.
Standard.
I mean, in this specific case, it's a low-risk patient. We want to leave a perfect result. For sure, we maybe...
But how much is what is the grading of the PVL from these 3 measures?
I would say from the aortogram, most people would say trace, the same from ultrasound, and probably the same also from the LVDP, which is normal. I think, but the finer grading on the LVDP, if I don't think you can distinguish a mild and a mild to moderate, and certainly not a trace from a mild on the LVDP alone. The trend in the field, though, is to go, you even think that a mild PVL is probably undesirable in the long run, although there is not much data on it. So I think over the coming years, we will advance more and more and have aim for less and less PVL. But we can conclude for sure in this patient.
So Andreas and Nessa, this was a very nice demonstration. Yeah. I would suggest that you just keep working. We can follow you here on the screen, and while you finish off this case, we can maybe have some interaction here with the audience in the room about what you think. Is there any question?
Yeah.